program, we'll talk about our patient population, about complications and outcomes of ECMO patients, and most important, we really want to show how important our non-ICU colleagues are in caring for the patients with the history of ECMO. And then I will turn over this presentation to Dr. Bailey, who will tell us about the risk adjustment models to actually predict and hopefully improve the outcome of our patients with ECMO or candidates for ECMO. So I would like to start from the introducing Maddie, as her story truly showed the importance of ECMO support being available for our patients. So at the time of the presentation, she was a 13-year-old, very healthy girl who developed crushing chest pain and a respiratory distress during her swim practice. She was rushed to the emergency department with severe respiratory failure. Unfortunately, during the intubation, she had a cardiac arrest. We brought her once, but shortly after, she developed second cardiac arrest, and we were not able to achieve return of the spontaneous circulation. So the ECMO team was consulted, really fast mobilized, and within 45 minutes from the initiation of the CPR, the veno-arterial extracorporeal support was initiated. She was found to have aberrant left coronary artery and underwent multiple procedures, many days of ECMO. We were able to help her out with multi-organ failure, but unfortunately her heart function did not recover, so she went into implantation of the ventricular assisted device, and this January 2017, she received a heart transplantation, and she's doing wonderful. She sent us this postcard, and I just believe that if we would not have an ECMO available for this population of patients, she would not be with us right now. So what is ECMO? I know it's really intense, truly intense topic, so very brief overview. Throughout the presentation, I will be using two acronyms: extracorporeal membrane oxygenation, which that's the most common used terms for the ECMO, and ECLS, extracorporeal life support. And I really like the second term better because it just gives the general overview of the respiratory and cardiac support, doesn't indicate it's just for the respiratory failure. So what it is, it's really not a rocket science. It was perceived to be very complicated, very difficult to implement system, but actually it's actually quite simple concept. After placement of the cannula into the patient's vascular system, the blood, deoxygenated blood is drained, pushed by the pump through the artificial lung where the gas exchange occurs, and pushed back oxygenated blood into the patient's circulatory system. We do have two main types of the ECMO we are supporting our patients with. It's the support called veno-venous ECMO, which is designed for the respiratory failure. It drains deoxygenated blood from the venous system and returns oxygenated blood directly back to the venous system. So in order for the system to work, you do have to have a functional and adequate native patient's cardiovascular system. It does not bypass the heart. As opposed to the second type of ECMO, very commonly used as well, it's the veno-arterial ECMO, when this system was designed for the cardiovascular and respiratory failure support. It drains the oxygenated blood from the venous system and returns oxygenated blood directly into the arterial system. So here, we do bypass the heart, and non-pulsatile positive pressure generated by the pump is able to support failing heart and generate adequate blood pressure. So, very specific subtype of veno-arterial ECMO, and our ED physicians are more and more familiar with this type of the support, is the extracorporeal cardiopulmonary resuscitation. And this system is designed to support patients during the cardiac arrest when the return of the spontaneous circulation cannot be achieved. A good chest compression, good quality of the chest compression needs to be maintained throughout the whole process of the cannulations. It's easier to be done for the adolescent and adult when we are cannulating the femoral vessels, but it's actually quite challenging for the younger patients when surgeons have to access the neck vessel, and we still have to do good quality of the chest compression to improve the outcomes. And let me tell you a little bit about the history of the ECMO. So the first patient was actually an adult with the severe chest trauma, aortic trauma, respiratory failure. He was supported in 1971 and survived. But as you can see, at that time, the contraption took the whole hospital room. And let me show you. This is the oxygenator. So it's pretty much like the bigger than the car tire, and yet we were able to do it. Despite of that, adults really for a long time did not believe in the effectiveness of ECMO. And I think some of it was related to first randomized controlled trial released for the adult with the respiratory failure in 1979 in JAMA, which did not show improvement in survival. But caveat for that study is both arms of study were super sick patients. The survival for both was 10%. So we were starting to think that they just put the two sick patients on. They were deadly sick. No matter what we do, we were not able to support them. And in terms of the pediatric ECMO, the first pediatric patient went on and well supported in actually 72. That was the post-cardiac mustard procedure patient and survived. And since neonatal first patient, the pediatric ECMO and neonatal ECMO took off. So the little baby here is a baby Esperanza. She was the newborn with the meconium aspiration, severe respiratory failure, abandoned in a hospital. So the nurses named her baby Esperanza Hope, and she did very well. And you can see her at age of 21 with Professor Bartlett, who put her on ECMO and saved her life. There were multiple studies, randomized controlled trials done for the neonates since then, and all the three early one for the general respiratory failure in a newborn population, patients with the persistent pulmonary hypertension, all the neonates from the United Kingdom, all those studies did show benefit of survival for those patients. And there is a Miss Esperanza graduating from the medical school, and Professor Bartlett is putting the white coat on her. So this is truly the end of the absolutely wonderful story and showing, again, how important this support is for our patients. And just as I mentioned, adults were not leaders with advancement and development of the ECMO, neonatal and the pediatric programs. And as you can see, after the initial spike in the neonatal runs, early 90s, as the conventional respiratory support developed better, we slowed down a little bit, but still quite significant, 700 to 900 runs a year for decades for the neonates, and keeps steady. So that's really biggest contribution to the ECMO patients population. Pediatric patients started a little bit slower, but still quite nice support, and steadily number of the pediatric patients supported on ECMO is rising. In terms of, I'm sorry, this really didn't translate it well, but in terms of adult ECMO, there were like the two pivotal points when they finally decided, well, maybe actually ECMO is effective. That was the randomized controlled trial in 2006, CESAR trial from the United Kingdom, when they randomized two populations of the patients, conventional mechanical ventilation versus ECMO, and all the patients were taken to the large ECMO centers in the United Kingdom. It not only showed benefits of the survival for the adults, but also cost effectiveness. So since that moment, the adults say we should do it. We'll see if we can support our patients. And to the point that in 2017, in the Trauma and Acute Care Surgery Journal, there was a paper released that we are starting to have adult lung rescue units. When they just put all the adults for the VV supports on the ventilators, they had 49 patients over the 1 year, 73% survival, and those patients are doing very well. It's not just about the survival, but also how those patients are cared for. Many of them are extubated, mobilized, doing PT, OT, and rehab during the recovery of the acute lung illness. And this is just illustrating the point where the adult ECMO took off after those two, first 2006, the Caesar trial, and then pandemic, actually, and H1N1, where many adults who were dying from this type of the influenza were placed on ECMO, and adult ECMO took off from that point on. And again, going back a little bit about technology development, huge contraption. There you go. That's where we are, guys, right now. And this box on the top, it's a pump, and you cannot even see the oxygenator. Oxygenator is tucked in the back of that box, and it can work independently. Our intermontane system has about 12 of those units, and they are mobilizing them for the adult cardiac patients and to transport those patients between the centers or within a center. And if you find yourself to have a heart attack in Paris, they actually you can find yourself to be cannulated on a field with that device and in a hospital, taken to the cath lab and have a chances of survival. So plan your vacation. Japan, Australia, France, Germany, Sweden, they do that. And we do have our own organization. This is the ELSO, Extracorporeal Life Support Organization. It's a consortium of the health experts and the centers dedicated to development, evaluation, and improvement of the ECMO. This is our place when we try to standardize care for patients with ECMO, and this is our Achilles heel. We just cannot still, for decades, find the common ground for the institutions to do ECMO somewhat similar between the places. It's still large registry. It is only ECMO-specific registry and our major source of the data and the research for ECMO, but there's some work to do for sure. And again, Professor Bartlett, I had a privilege to work with him and learn from him. Just brilliant and wonderful human being who is considered to be a father of whole ECMO support and system. And active ELSO centers, as you can see, again, starting 2007, 2008, when the adults joined our efforts, spiked tremendously from about 100 to 300 centers. It's including 50 countries on all continents, and it is really international effort to improve care for those patients. What was the ECMO history in Primary Children's Hospital? So our first neonatal patient was placed on ECMO here in 1987. And we did actually have a very good neonatal outcomes, but pediatric outcomes and cardiac pediatric outcomes were not so good. So the program was suspended because we just did not have a well-developed infrastructure for those patients and no staff. So between 92 and 2002, we did not offer ECMO for our patients. Until 2002, we joined the ELSO organization. Our program was reviewed, revived, and since then we are doing fairly well, and every year I think we are doing better. PCH ECMO volume by unit and time of support. So as you can see, the neonatal intensive care unit is leading the pack with about 78 patients supported over the last 5 years. PICU is following, and the CICU, PICU 75 patients, and the CICU 45 patients. In terms of the veno-arterial support, again, surprisingly, you may say that NICU is leader with the highest numbers, even though predominant diagnosis for our NICU patients is respiratory failure, but those patients are small, premature. We are just not able to put one large double lumen cannula into the vascular system. So very often we try, but at the end we have to end up with the veno-arterial support for those patients. No surprise that venous is still predominant mode of support in the NICU and PQ. CICU, so the eCPR, that is a little bit concerning to us that more of our cardiac patients is going on ECMO in eCPR mechanism more than VA, like more, we call it elective. I don't know, it sounds weird that you are talking about the ECMO as an elective procedure and support, but yes, if we can put those patients earlier, before they arrest, it's huge in terms of the outcomes and avoiding the major, especially neurological complications. So that is our task, and we really are working hard trying to reverse those numbers, decrease the number of the eCPR patients. And in terms of the PCH ECMO survival, and this is, I'm sorry, should be over last 5 years, the blue bar on the back represents surviving ECMO to decannulation. So those patients have to be alive at least 24 hours after we take the cannula off and stop support. But more important for us is the red bar, which is the survival to discharge. So it's not just getting through the ECMO process, but also have a good outcomes at the discharge in the hospital and being able to survive at the time of the discharge from the hospital. And we do have a little bit ups and downs, but overall trend is very encouraging. Those outcomes are pretty good. And that's how we compare to our overall registry and ECMO centers. Also, groups patients a little bit differently. They go more by age and total, like general type of the support for the ECMO patients. So we have a neonatal respiratory, neonatal cardiac, and a neonatal eCPR. Those are the patients between 0 and 28 days old, and the pediatric patients 28 days old to 18 years of age. But doesn't matter how we divide it, we report the same to the ELSO, and in all categories, we are either comparable or better survival. So again, I think we are doing fairly well in PCH since we started the program in 2002. But since we are talking about the survival and mortality, I just wanted to present what are the very general causes of our patients not surviving ECMO. So I divided this group to, again, 2 did not survive ECMO. So those patients in the first part were not alive more than 24 hours after the ECMO was stopped. And as you can see, the biggest group is the devastating CNS injury. And this is really, again, the most just the worst complications we do experience, the patients on ECMO experience. And it doesn't mean that the ECMO caused all those CNS complications. There is a big contribution of ECMO, but many of those patients did go on in an eCPR mechanism, so they did have a low flow state, hypoperfusion, and arrest before we put them on, and that really affects the outcome of those patients. We do have a patients we just cannot support on ECMO, so we put them on. We are hoping to reverse the pathology, but the multi-organ failure progresses. They may have a very poor prognosis in terms of the underlying either cardiac or the general pediatric or neonatal pathology, and we cannot save them. There are some which do have a concomitant CNS injury, but with this red pole, the CNS injury was not the main factor in withdrawing, in making decision to withdraw care from ECMO. And some patients, again, they just have a really bad underlying disease we could not reverse. And from those patients who survived, again, just progression of the multi-organ failure, the underlying either genetic conditions on underlying cardiac, congenital heart disease, no options for the repair, and the decision was made. Or we did have a patients who developed sepsis later, other acute illnesses totally not related to ECMO, but they did not survive to discharge. So they are included in that group as well. So ECMO criteria. So what do we go by? How to make decision that the patient is a good candidate, that we should offer the ECMO support to those patients. And to be honest with you, this is the most difficult decision we are facing with the whole ECMO support process. At least in my opinion, I am thinking my colleagues from the unit will echo that concerns, that we really do not have any standardized indicators which patients will do well, which patients will not do well. And for years, we tried with ELSO, find, is it the length of the ventilation? Is this the underlying pathology? Oxygenation or circulatory status before ECMO. And really, as you can see, really there is no accurate predictor markers. And I will not dive into this because this is what Dr. Bailey will talk to us after my part of the presentation. I just want to show you this graph because there is one principle which still holds. This is from the green papers from 1996, so pretty old. But if you put too healthy, if the patients are not sick enough for ECMO, you will die from this support because you will die from the complications. If you are super sick, I mean, no matter what we do, ECMO, no ECMO, any type of the procedure, they will die. So optimally, you would like to catch them in this group when the mortality risk is like 50 to 75%. The problem with that is there's really no good pediatric predictors like mortality scores. So PIMS, PRISMs, they were not designed to assess the individual complex critically ill patients' outcomes and mortality. So it's very hard to apply. So I'm still waiting for the advancements in technology, for the accurate predictors for us to know which patients will do well. So there is a hope. But also what we go by clinically. So early identifications of the patients is key for us. We are looking for the potentially reversible condition, and preferably ECMO should be bridged to recovery. We wanted those patients to end up with the functional and the health status they had before ECMO. But very often we don't have a time, and I know that our neonatal colleagues are struggling with that, or not struggling, they're actually quite good with this support, but those babies are sick right away. We don't have a days to run diagnostic tests and see how they respond to the mechanical ventilations or more advanced support. We have to make a decision because otherwise they will not survive or have very bad outcomes. And some patients we know that may not recover. The myocarditis patients, if they lose and don't recover myocardial function, that's the bridge for the ventricular assisted device or heart transplantation. We definitely are looking for the conditions associated with high risk of mortality and morbidity, again, high chances of dying without ECMO. But now more and more we are looking for the comorbid conditions. There's many patients. 20 years ago, only healthy patients and 2 genetic disorders, trisomy 21 and DiGeorge, were candidates for ECMO. Now we have a whole list of the various conditions as long as the patient has a good quality of life reported. We did have a patient, with the CP, with other conditions, great quality of life. We had the kids from the South Davis with the tracheostomy, went on enough. We called providers. We talked to our consultants. Hey, talk to the families, trying to get sense what is the quality of life of that child, because the chances are that they will have a CNS injury and we may worsen it. So you don't want to get from the level of barely acceptable, good, but very touchy, to something which will not end up well for the patient. So again, going back with all those clinical indications, early identifications of the patients eligible for ECMO is the key for us to assure that maybe the outcome will be better. Contraindications, do not read this list, please. This is just to illustrate how many contraindications we had 10, 15 years ago. And this is just a pediatric list. I didn't put the cardiology and the neonatal contraindication list, so it's long. Now, almost none. So all the statements from the ECLS are saying case by case, again, quality of life, assess every patient. We did not put the patients with the cancer, hematological disorders, autoimmune disorders. All those patients are eligible right now if it's the right patient at right time. The neonates still do have a few strict criteria, and it's mainly the gestational age of 34. We do not put younger than that neonates, and if they are smaller than 1.6 kilo, because we just can't put cannulas in that little of the baby and support. So we do develop some contraindications. So the major contraindications, irreversible neurological injury, if we know that the patient is coming after major arrest and we can expect that the hypoxic anoxic injury is severe, will not put those patients on. Severe irreversible multi-organ system failure, terminal disease, incurable malignancy. We do have lots of discussions with our heme colleagues if we have a severely sick leukemia patients or the bone marrow patients or with any other cancer. And we did put some cancer patients with a very good outcomes on, and they have a good quality of life. Inability to anticoagulate. So the big thing with ECMO is that those patients are fully heparinized, so this all plastic tubing and the circuit outside of the body will not clot. So obviously it puts very sick patients in a huge risk of bleeding, and the neonatal patients for the intracranial and overall organ system bleeding from all the organs. And the absolute contraindications are rest outside of the medical center. So the ECMO indication, just give a couple example of the patients. Easy, not so easy. So this young lady, 17-year-old, previously healthy female, presented to the primary care physician with the several days of the illness thought to be infectious cause. On a day of illness 3, she rapidly progressed to the respiratory failure due to necrotizing pneumonia. She developed hemodynamic instability, required pressor and inotrope support, developed renal failure, pulmonary hemorrhage, was on super high ventilatory settings, transferred to the primary children's a little bit too late. I would love to have these patients earlier coming to us so we can implement the treatments a little bit earlier on very high ventilatory settings, borderline oxygenation on 100% supplemental oxygen. We right away, within 2 hours of the arrival to PICU, she was cannulated for the VV ECMO, and this is her X-ray. So for us, this is the easy patients, previously healthy, reversible disease. So we think this is our longest ECMO round for the PCH ever. This young lady was for 36 days on ECMO, and she did have a tracheostomy and vent support for just a couple months after the decannulation. She's in a college, doing great. She probably will not be the Olympic runner or swimmer because of her lung capacity, but she is doing quite well. As opposed to this patient, we have a 2-year-old girl with the idiopathic rheumatoid arthritis, developed respiratory failure due to possible pulmonary fibrosis. Terrible diagnosis, right? But we don't know. And plus minus opportunistic infection on chronic immunosuppressive therapy and a pulse doses of the steroids given for this possible pulmonary fibrosis. Very limited diagnostic options. Patient was just too sick on a high ventilatory settings. We couldn't do lung biopsy. We couldn't repeat the bronchoscopies, nothing. And she was deteriorating. We were sitting on this kid for about 2.5, 3 days trying to make a decision with multiple ICU physicians and consultants, should we put her on or not? If this is the pulmonary fibrosis, will we be able to reverse this process and not go to nowhere, bridge to nowhere with ECMO? And she still just had a single organ failure. Everything else was working just fine. So the decision was made to put her on. She was on for about 10 to 12 days. She had lots of complications and other superimposed illnesses. But there she is with her wonderful family. She is a trooper, and she's running right now. They are taking her off the vent. And I think she will actually have a pretty good life. So they're visiting us all the time. Like every few weeks, they're strolling through the units, which is so nice for us. Another thing is, so who are our patients, And I put the NICU underlying diagnosis is what we think the newborn are before we put them on ECMO, what kind of diagnosis they have, and before the acute pathology. So we think 50% of them totally healthy. We didn't diagnose anything in utero, genetic disorders, or were expecting that something bad will happen. The 32 of our ECMO populations did have a diagnosed prenatally congenital diaphragmatic hernia, genetic disorders, and all the other small contribution of the cardiac patients, arrhythmias. So the reason they go on ECMO is meconium aspiration, congenital diaphragmatic hernia, persistent pulmonary hypertension, sepsis, and others, some cardiac arrhythmias, all the back of the other diagnoses. The CDH outcome for the primary children is about 68% of the survival, PPH and MS higher than that, very good outcome. Sepsis is always the worst, between the 30 and 50% of survival, depending on how sick the patient is. For PQ, again, half of our patients coming to us and end up with ECMO, they are healthy. They really do not have any underlying conditions. 23% genetic disorders increase from 10 to maybe 15% over the last 5 years. And the chronic lung disease, prematurity with the trach vent and the technology dependence, we did not put those patients at all previously. But as long as they have a good quality of life after we take them off ECMO, we think it's acceptable to have those patients as a candidates. Pulmonary infections, our leading cause of the ECMO indications, and the sepsis, we still put those patients on terrible outcomes for the PQ, about 10 to 20% survivals only, but I'm hoping we will get better in the future. Very interesting population of the patients are the burn patients. We are having very good relationship with our burn center at the U, and we have more and more patients every year when they are brought to us with the severe inhalation injury for the ECMO support. This 11% others, very interesting as well. We had a few kids with the foreign body aspirations. They were arresting when we were trying to retrieve this foreign body in the OR, and we put them on VV. Take it out, take them off of the VV. We had patients, we had an intubation assisted with the ECMO because we just could not intubate otherwise. Really well doing child. In the CICU, just one pie, because the underlying cardiac diagnosis, indirectly or directly, at some point during this course, we'll put them on ECMO. So, except of the myocarditis, except of this blue slice, where we think that lots of those myocarditis patients were healthy before, but we have a congenital heart disease with genetic disorders, without genetic disorders, and separate group I put as a single ventricle, totally different beast with the different spectrum of the complications. And the complications. So the CNS injury, that's what we worry the most in those patients. We, unfortunately, our patients do experience ischemic infarctions, intracranial hemorrhages, seizure, and a global cerebral edema. Again, not all related to ECMO. It is very hard for us to make determination what kind of injury patients had already before the ECMO, how much ECMO did contribute. The bleedings and the focal injuries, hemispheric injuries, are usually related to ECMO, related to cannulation and the thromboembolic strokes. Also, hemorrhage, big thing, because we are anticoagulating those patients. So bleeding from the cannula side, from the surgical side. Majority of those complications do occur while patient is on ECMO, so we are taking care of that. But we did have a patients who bled after ECMO as well, from the aneurysms, from the fistulas of the previously cannulated vessels. So that's something we definitely have to remember with the follow-up. Higher risk of infections, vascular injury and insufficiency. If we put the femoral cannulas into the femoral artery, the limb-leg ischemia, it is really big threat for those patients, so we have to put the reperfusion cannula. But the vascular injury, we need to remember that when the patients are on veno-arterial ECMO, carotid artery, if they are going through the neck, is ligated. So the patients do not have a fully sufficient cerebral circulation. They have collaterals and the circus of Willis, but it's only left carotid artery left. So we have to remember about that for future as well. And for the VV ECMO through the neck, IJ is ligated. So this vessel is not accessible in the future. Some of our patients do have a reconstructed vessels, especially the cardiac patients for the future procedures, but many of them do not stay patent. They clot or they stenose. So still, again, something to remember about. And the risk factors for the CNS injury: pre-ECMO low perfusion state and arrest, carotid artery ligation during cannulation, thromboembolic events, anticoagulation, and hemorrhagic strokes. And just really briefly, one of our patients, 4-year-old, previously healthy boy with the influenza and bacterial pneumonia, severe hypoxia on high ventilatory setting, developed also septic shock. Neck vessels were cannulated for VV. We were able to maintain his cardiovascular status with the medical management, and he was doing fine. We were weaning him off ECMO. He was getting better, but on day 5, he developed the signs of the herniation, and that is his scan. So really, we thought this is a helpless situation. We talked to our surgeons and neurosurgeons, and nobody just didn't want to do anything. But the child was not brain dead. He was actually improving from the neurological status, so we continued to care for him, reversed heparin, took him off ECMO, managed him medically, and there he is. 1 year later, he has a left arm weakness, that's it. And he was running around in a cafeteria when I met him with the corn dog, and I was thinking, you went through all this stuff, and now you're going to choke on this corn dog. So it was like, really? And this is like our CNS injury by unit. So out of the total 197 patients, 63 patients had a some type, so 32% some type of the complications, CNS complications, reported and documented on or after ECMO. And only 25%, so 40% of those who had the CNS injury survived to discharge. So for sure, CNS injury, high risk of mortality. So we will do everything to avoid these complications if we only can. And NICU, as you can see, VV, VA, equal proportions of how much those kids either stroke or bleed. And this is most likely related to the underlying physiology of the newborn, higher risk in general for the bleeding, and they all have some degree of the HIE perinatally. In a PICU and CICU, VV, very low complications. Our patients are just older and they don't bleed as much, and VV is not as high risk for the ischemia. But as you can see, ECPR, again, going back to this previous slide when we really will try to reduce the number of the CPRs, and that's because of the CNS injury. And this is very interesting, actually. So the patients without documented CNS injury clinically, so no documentation that we had seizures or motor dysfunctions or anything else, and we have 133 patients without documented clinical signs of the CNS injury over the last 5 years. 105 survived to discharge. About 50, a little bit over 50% had a follow-up scans, even though there was no clinical signs. And about a third of those scans were positive for the either resolving bleed or the some ischemic changes. What to do with those patients? Good follow-up, because I will show you a few citations. It was studied actually and evaluated. Even though patients on a discharge from the hospital don't have a documented injury, they do have a neurodevelopmental issues in the future. So they do need the good follow-up with our outpatients physicians. And how we compare to the ELSO, again, CNS injury is a big thing for us, so we will need to work and try to make determination why our centers, it may be patient population, it is very, very hard to compare because we don't have an individual centers data, and the management is all over the board. So we just really don't have a good way to compare of our patients, but we know that there is issue, and we'll try to work on it. Same pattern for the cardiac ECMO patients. And in the Pediatric Critical Care Medicine document released, paper released in 2015, showing the association of the bleeding and thrombosis with outcome and extracorporeal life support. And definitely bleeding and thrombosis, higher risk for morbidity and mortality, with bleeding actually being bigger contributor, more significant morbidity and mortality than thrombosis. So we will work on that outcomes literature. So this is just the few latest outcomes papers. There's lots of good literature on follow-up of the, especially neonatal patients. Like I'm saying, neonates are leading in an ECMO field, and they are doing very good job, and we are trying to get example from them. This very first paper, ECMO in neonates, neuroimaging findings and outcome, really good one. I really advise to read it if you are interested in outcomes for the patients, because it summarizes all the other papers as well. And it shows that not just the patients who do have a documented CNS injury on ultrasound, MRI, CT, and clinically, but also those patients I showed you without clinical signs, they do have a lower neurodevelopmental scores, pediatric quality improvement scores. Those patients do need follow-up as well. And it actually carries through the pediatric and the cardiac literature as well. And a follow-up, we do have a well-established neonatal follow-up program through the University Development Assessment Clinic. And just big kudos to all our physicians in outpatient clinics to help us with those patients. Very strict visits with the neurodevelopmental testing, PTOT testing, speech testing, but those patients are followed up in that clinic up to the age of 5. Then they go to school, and it's up to our pediatricians to look at the results of those tests, follow up with that, because one of the biggest pediatric quality scores is the learning disability and some type of the behavioral attention. Yes, so definitely those patients deserve good follow-up. And I really would like to advertise our cardiac neurodevelopmental clinic, guys. We are trying to recruit the patients. All ECMO patients do qualify for this clinic. And this is part of the University Developmental Assessment Clinic. And we have brochures, and you have links to that. We do not have a structure, ECMO focus, like after discharge, those patients are not automatically referred to that clinic. So again, up to our pediatricians, if they kind of fall off the radar. Some of them follow up with the general congenital heart disease or heart failure clinic, but again, not specifically for the ECMO survivors. And nothing for the pediatrics. We do not have an established pediatric follow-up. And again, I just want to finish up with this wonderful Mr. Mitchell, who is true superhero. He went through a lot in a NICU. He still have a alveolar capillary dysplasia, so we don't know in the future what his outcomes will be, but he does have a stellar follow-up. So there he is in a NICU. There he is as an all grown up. And I don't know, we have all those physicians who are, just a second, just have to get him. I don't know why it doesn't work. Anyway, it should have a video when he is riding this BMW, by the way, so very good outcome and high standard of care. I don't know who gave him the test and stuff for the driver license, but there he is. And I will turn over this presentation to Dr. Bailey. And again, just want to acknowledge our wonderful ECMO team. Michael Oprowski, our manager. This program would not exist without support of all the people. So cardiac surgeons, general surgeons, our 9 primers, 40 specialists. And that's when we were receiving the also award for the Center for Excellence.
Thank you, Anya. Wonderful overview overall. There may be one benefit of ECMO is I might not feel my heart pounding in my chest if it wasn't really beating. But so in the next 10 minutes or so, we're going to answer this really easy question: is ECMO worth it? We've learned that this journey on ECMO starts with a single decision, and that's to put the patient on. Hopkins recently presented a patient, 60 days of ECMO, 400 days of a right ventricular assist device, went on to have dialysis, lost a limb, multiple infections, ultimately went home, went on ECMO for an inhalation burn injury. So something that we would think would be a straightforward ECMO run. But it starts with this single decision, and that's to cannulate the patient. And that decision is very difficult. We have to measure this in healthcare somehow, and we've adopted the value equation. It's an equation of proportions. which from a cognitive aspect is just difficult for human beings. We mess this up constantly. But it's something over something, and when either the numerator or the denominator becomes infinite, the equation starts to break down. So for our families, what they're looking at as an outcome is to live or to die. And so the numerator becomes infinity, and despite the costs, which are broad and high, it's difficult to say what the value is overall in that circumstance. Clearly, for these patients, it's worth it. These are some blogs from parents of children with congenital diaphragmatic hernia, and to them, it was worth it. One person didn't survive, one person survived, and one person said it didn't matter if they survived or not. It was worth it. It gave them a chance. This patient here on the right, on the right, this is a teenager. He had two loves in life at this time. He loved his red Converse, and he loved kissing his girlfriend on the front steps of his house. He also had a lethal arrhythmia, it turns out. And when he combined his two loves, his lethal arrhythmia came out, and he went into a VFib arrest, 45 minutes of CPR. His dad was an ER doc. His dad said, had this have been an adult that rolled into my ER, I would have stopped. Because it was my son, because he was young, we kept going. They brought him back. He came to our unit. He developed ARDS and went on to VV ECMO in the cardiac unit. We put his red Converse on ultimately, and he walked back out of the unit. So if you ask these patients and these families, is it worth it? Obviously, the answer is yes. But at a population level, that's clearly not an approach that we can take with everyone. And so we need to find a way to try to understand who enters into this world of ECMO and how to do it in a rational approach. There's basically two big domains that determine patient outcomes. First are your pre-ECMO patient factors. Now, historically, we've looked at this as this is a patient. But I want you to think about this in a little different way. Rather than a single patient in block, think of each one of these little smiley or sad faces here, these icons, as a feature about a patient. So, for example, this may be whether you're term, preterm. This might be you have a diaphragmatic hernia. This might be your pH. So each of these represent different features about a patient. And a constellation of these features determine what is your risk of living or dying before you ever went on ECMO. The second thing is this ECMO care processes. Now, it's already been alluded to that there's a lot of variation in the way that we care for these patients, the way we cannulate them, the type of circuit, anticoagulation, and so on. It varies not only from center to center, but across the world. And all these things lead to outcomes. Now, it makes sense that a good patient ends up with a good outcome, and maybe a bad patient ends up with a bad outcome. But now and then we have patients that kind of cross the chasm, right? We have good patients like this burn patient that I mentioned, and somewhere in the process they end up having a really bad outcome. And we have patients who you'd think would do really poorly, and somewhere in the middle they cross over and they have a good outcome. So somewhere in this world of practice variation, their life is morphed and their outcome becomes anew. Extreme example, hypoplastic left heart syndrome, transposition of the great arteries. This used to be basically uniformly fatal within the first few years of life. We learned the patient factors were bad for these patients, but through ECMO, we were allowed to offer them a therapy, a surgery that we couldn't offer them without ECMO. And because of that therapy, because something that happened in here, their outcomes are dramatically different now. Another example, an adult woman, she had was listed for lung transplant. She started having recurrent pneumonias, necrotizing pneumonias, and so every time she got an offer for a lung, they had to turn it down. Through multiple forms of extracorporeal support, she actually had both her lungs explanted, taken out of her chest, listed for lung transplant, received a donation, and survived. So you can see that the ECMO process itself works because it's a bridge to something, whether it's a bridge to additional knowledge or a bridge to a therapy. And some of these therapies, as I've mentioned, they took a lot of courage and they took a lot of innovation. And it's an opportunity for people to realize that ECMO is a care process, but it's an opportunity also for us as physicians to think about things in a totally different way. And perhaps the ECMO circuit itself offers adjunctive therapies that wouldn't be offered otherwise. There's another case study of someone who just put a patient with renal failure and hypercarbic respiratory failure, stuck an oxygenator and lying on the dialysis machine, and never put the patient on ECMO. But again, it was an opportunity to think outside the box and change this care process. But in order to differentiate between the patient factors and the care processes is important. And in order to do that, there's a small group of us who have started to try and separate it out. And what we've done is built these risk-adjusted models where we take patient features only, pre-ECMO patient features, in large data sets such as the ELSO registry. And through various forms of statistical analysis and regression, certain variables come to light that are important and that actually are predictive of survival. Now, you can see the area under the curve for all these models is only modest at best, but it's hard to get a really good model when 50% of your patients live and 50% of your patients die, which is about what we deal with in the world of ECMO. But these variables become interesting. And here's a chart. Not to get into all the details of these variables for this discussion today, but just some of the things that we've learned. These are some of the variables across all these models that are favorable and some that are unfavorable. Now, a lot of these aren't a surprise. We know that meconium aspiration in neonates a good combination. We know that being preterm and having congenital diaphragmatic hernia or congenital heart disease is not as good of a combination. But what was alluded to already by Dr. Hubbard, and what we're learning is that these comorbid conditions are actually influencing mortality, in many cases, even more so than the primary reason for which they went onto ECMO. Liver injury in the form of elevated INR, bilirubin, PTTs. Renal injury is interesting. In initial models, it was very predictive of mortality. In more recent models, it's falling out. Now, whether this has to do with practice variation, we don't know. Documented bloodstream infection. In the most recent model, the only thing more predictive of death is ECPR than documented bloodstream infection malignancy. Now we can see some of these are bolded in asterisks. These are factors that as clinicians we can potentially in some way modify. So of course we'll continue to focus on defeating the primary physiology requiring ECMO, but now we can simultaneously work to defeat the patient factors that make ECMO so risky right up front. And some of this has to do with timing. Earlier cannulation, different support strategies up front, more rigorous screening for infections right out the gate, more support for bleeding diatheses right up front. There's all sorts of things that may potentially help us out. But getting at these patient-specific factors is extremely important. Now, if you dive into one of these models, link into one of those sites, you'll see something like this. Now, while these models were all built on a population level, on a patient level, it's still the best we have. Is this going to play or not? Doesn't look like it. Well, if it played, what you would see is you can pick variables. You can kind of pick different features about your patient. How well are they oxygenating? What's their pH? What's their pulmonary prognosis? Do they have comorbid conditions? And ultimately what you end up with is a score, and you end up with a risk of survival. And it's adjusted along the way. As you pick features, you see how your risk of survival changes over time. Now, while this is not perfect at a patient level, this is kind of what you'd see. This patient had a score of 8. I think it's still better than this 8. And this is kind of where we've been at, you know, we're like, not yet, need more information, you know, so at least now we can start to understand a little bit where we might be going and talk to families and build trials around these patient features. But the two big things that this offers, it offers us the ability to risk adjust in 2 ways. And the first is we can risk adjust for mortality across centers. I sat down with the chair of ELSO registry a few weeks ago, and we looked at risk adjusting for across centers and across the world. And I can tell you that the degree of illness of patients going on ECMO is highly variable, even from country to country. Some countries are waiting a long time. Their patients are really, really sick when they go on. So comparing their outcomes to someone else's outcomes doesn't really help. It's not really fair. But even more importantly, what we can now do is build these observed to expected outcome models. And what these do is they adjust for the patient-specific factors, and what you're left with is, in more degree, what you're left with is center practice or variation, that middle zone, these things we're actually doing. So these centers here, if this was survival, given the same case mix, more patients survive here than survive there. Now, you can't say that this center is better than this center because you don't know how this center would perform if they had the exact case mix, but you have adjusted for the patient factors. So what that means is we can now see centers that are performing worse than centers with poor patient features are doing something to get better outcomes. Whereas these centers, even though you expect more of them to survive, they're actually dying. So we can look at practices in aggregate at this center, look at practices in aggregate at this center, hopefully continue these practices, get rid of these practices, and move this group that's a middle performer up into the higher category. But without the ability to risk adjust these patients up front, it's very difficult to know which patient practices are actually influencing mortality versus it's the patient features themselves that were up front going to cause the end outcome. So overall, we hope that, one, we can be a little bit more informed right up front, understand what we're doing when we put them on. Two, we can approach our care processes and our ECMO care in a more strategic, more rigorous, more replicable way by understanding the care processes that we all provide that make a difference and ultimately improve patient outcomes.
Any questions? Sorry, I'm blinded by the...
Anya noted that increasingly we rely on decisions about who to go on based on quality of life. Certainly a very subjective measure that continues to change and evolve as opposed to a more objective scoring system. Given that the definition of quality of life is so dynamic, would you give us some examples of things that would preclude, in your mind, going on?
Yes, so again, our main contraindication is the intracranial pathology. I mean, if the patient had a prolonged arrest before, and we do have a signs of poor neurological outcomes. Before we go on ECMO, we very often try to get neurological examination on those patients. If we do have nothing, we really discourage placing those patients on. Example, we had two patients with the cold water drowning. We have a program in a primary children's hospital when we have lots of patients drowning in a very cold streams or the avalanche victims. We had two patients who had a prolonged arrest, terrible scans, severe respiratory failure, but on a day 2 of the hospitalization, and we did exclude them as an ECMO candidacy because that's just what we are seeing in the future. Those patients are doing very poorly, but neuro exam was improving. The one boy we were able to truly wake up, and he had a severe respiratory failure. We did put him on, he survived. He does have a mild hemaparesis, but he's doing very well. And majority of those patients, if they don't wake up, they don't have any good signs that they may recover. We try to scan them, talk to the parents, and will not put them on. Cardiac disease is or the congenital heart disease. We have many patients when they actually have they are barely compatible. They are not compatible with the life before the surgery, barely compatible with life after the surgery. No options to repair, and they are getting worse. We would not put them on repeatedly if, let's say, they have a neck or sepsis because the cardiac conditions is precluding them from going on. Trisomy 13, trisomy 18, some of the genetic disorders, we know that those patients are not doing well and have a progressive irreversible conditions, fixed pulmonary hypertension. We cannot reverse that. So we truly, liver failure. I mean, we do not have an ECMO liver support. If you are in a fulminant liver failure, this process is extremely hard to reverse. Technology dependent kids, like I was saying, 5 years ago, 10 years ago, we would not put the trach vent kids on. Now we do have many which went on, but again, discussions with the parents, providers, will we decrease the quality of life of those patients after they are separated from ECMO or go over the acute illness? We don't want an ECMO and acute illness add to the miserable life of those patients afterwards. It is extremely hard. It is the most difficult decision, guys, to make decision if the patient is an ECMO candidate or not.
Wrap up.
And so in discussion with the other authors who built all of these models, we all agree that they weren't designed, they weren't built at a patient level. They're all population-based models, but it is the only patient-based decision tools that really we have available. We use them as an aggregate, I think, to say, this is what we kind of think is our overall risk. I think it helps calibrate the team probably more appropriately than it calibrates the patients and their families in that standpoint. We do not have a uniform way of incorporating this into the decision-making process. We've had very, very preliminary conversations about it. We've pulled up the website during ECMO discussion on rounds, but we haven't formalized the process. These risk-adjusted tools are going to be incorporated into the ELSO registry in the next month or two. All the data will be represented in this way. When that happens, I think we'll have a lot better ability to understand what the implications of them are. And the hope is to use them to get at practice variation just as much as it is to get at decision-making.
We need to wrap up. Dr. Bailey, Dr. Hubbard, thank you.